and the role that the Wexner Medical Center plays during this pandemic. I'm Gail Hogan. I will be your host for the discussion this evening. A few housekeeping items before we get started. All attendees, with the exception of the panelists, are muted. The session is being recorded and will be available within the next few days. Throughout this webinar, please submit questions for the panelists, and we will try to answer as many questions as we can during our question and answer portion at the end of our discussion. So let's get started. This is the fourth webinar in our weekly series, and this week I am privileged to have with us three experts leading Ohio State's efforts in the battle against coronavirus, but also in the recovery of our communities. First, let me introduce Dr. David Cohn. Dr. Cohn is the Chief Medical Officer at the James Cancer Hospital and Solove Research Institute. He's a physician scientist whose clinical practice is based in gynecologic oncology, and research focuses on the early detection of ovarian cancer and the genetics of endometrial cancer. Dr. Cohn is responsible for the COVID-19 responses for the clinical care of cancer patients. Welcome, Dr. Cohn.
Thank you, Gail. Great to be here.
Next, please welcome Nwando Olayiwola. Dr. Olayiwola is chair and professor of the Ohio State University Wexner Medical Center's Department of Family Medicine. Dr. Olayiwola has played a critical role in rapidly expanding telehealth care at the Wexner Medical Center and to continue to care for patients during the COVID-19 pandemic. She is also a leader in organizing the medical center's collaborative efforts to improve health equality and to reduce COVID-19 disparities, and is leading the charge to facilitate more conversation and resources to care for the underserved communities in the Ohio State community. Thank you for joining us, Dr. Olayiwola. I'm going to say it, Olayiwola. Finally, please welcome Dr. Andy Thomas. As Chief Clinical Officer of the Wexner Medical Center, Dr. Thomas collaborates with other medical center leaders on institution-wide initiatives related to clinical operations, outreach, patient safety, and experience, and the integration of our hospitals and physicians. Dr. Thomas also serves on Governor DeWine's Healthcare Advisory Council. Welcome, Dr. Thomas.
Thanks, Gail. Great to be here.
So we do have a series of questions to ask each of our panelists, and when our discussion is complete, we will open that dialogue to questions, and those questions will come from you, and we will try to limit that Q&A to 15 minutes. And Dr. Thomas, I'm going to start with you. It's been about 4 weeks since we last met here on this discussion, and as we've learned, everyone's learned, a lot can change in a week, a lot can change in a day when it comes to this coronavirus. Are there any new precautions that the general public should take other than what we've been hearing, masks and social distancing and hand washing?
I think it's a great question. With the reopening of the state, it's a little bit different scenario than it was 4 weeks or 6 weeks ago, when pretty much most people were staying at home, only going out for, kind of essential trips to the store, et cetera. Now, as more stores are open, more businesses are open, I talk about this with my patients all the time. I think especially as people are considering summer vacations, going out of town, the short answer I always have is the best thing you can do is work to control your environment. So if you have the chance to go somewhere and you can drive there in a car versus fly there in a plane, you're much better off to drive there in your own car. You can control who's around you. You control what gas station you stop at, et cetera. On a plane, you just have less control. If you're going somewhere and you're renting a house and only the people that are going to be there are your family, as opposed to being in a hotel where you have elevator buttons to push and the counter in the lobby to touch and other things, the more you can control your environment, the better. So as you think about going out to stores, out to businesses, or back to work, the more you can be in your own office, the more you can make sure that you're keeping 6 feet away from other people. You can't always control what they do, but trying to go to stores, certainly when there are fewer people there, is important. Many stores, especially for folks that are over a certain age or first responders, have special shopping times. But I think we all know there's times when stores are more busy on, say, Saturday or Sunday than they are Tuesday afternoon. Trying to just do whatever you can to make sure you're keeping yourself safe. Now, you mentioned a couple things with masking, hand washing, all those things are important, but it is really important to remember that the wearing of the mask is much more about protecting others from you than you from others. And I'm sure we'll talk about this a little bit more tonight, but the asymptomatic positive rate for this virus is higher than I think all of us would have expected it to be. So when, nobody wants to think that they're going around infecting other people, but that's really the power of wearing the mask, is you are protecting those around you. And certainly if you have to be in an environment where you're within 6 feet of others, you really have to wear a mask for that purpose.
So again, this is to protect other people, and we're all doing our neighbors a favor by doing that.
It's a team sport.
Dr. Cohn, we know that cancer patients are among those people with suppressed immune systems, making them especially vulnerable to the COVID-19 virus. What are the extra precautions that the James has been taking to keep cancer patients healthy and safe?
You know, I think that this is a great piggyback to Dr. Thomas's comments in that we know that cancer patients are uniquely susceptible to contracting COVID-19 because their immune systems may be damaged by their cancer or by their chemotherapy or radiation, which also means that if they get COVID-19, they're at specifically high risk for having complications of requiring intensive care unit stay, being on mechanical ventilation on a respirator, or even dying from COVID-19. So I think that that vulnerable population is a very special one that, very early on, the James, as part of the Wexner Medical Center, recognized the importance of, as Dr. Thomas said, hand hygiene, social distancing, being physically apart, being in a position to ensure that masks were undertaken, and then also in the highest risk population, doing testing for COVID-19 before being in a situation where someone's immune system would be damaged by chemotherapy, making sure that that individual doesn't have that COVID-19 infection with no symptoms prior to putting them at risk for having COVID complications. So those are the extra precautions, but I think that in principle, everything that is being done in the general population is exactly what's being done in the James and with the cancer population as well. I think it's just critically important that we're in a position to make sure we protect the entire community.
Dr. Olayiwola, let me ask you this. When we're talking about specific populations and vulnerabilities, what are the key health disparities that have been exacerbated by COVID-19?
Yeah, thank you. And I certainly want to piggyback off both of my colleagues, Dr. Thomas and Dr. Cohn, because they spoke about vulnerability based on cancer diagnosis and status. But I'm going to speak a little bit more about socio-cultural, socioeconomic factors that have really led to a lot of vulnerability with COVID-19. We've seen pretty stark disparities in the impact of COVID-19 on racial and ethnic minorities, as well as economically challenged or low-income individuals. We've also seen disparities in the experience for people that are immigrants or refugees, and certainly people in congregate housing arenas or in correctional facilities as well. And part of the challenge that has created is that many of those populations are folks that are essential workers, as Dr. Thomas was talking about earlier. As people start thinking about reopening or going back to work or staying in work, these populations really do need to be protected, and it was striking to see the differences. In Ohio alone, we've got a situation where African Americans make up about 13% of the population, but 23% of the cases of COVID-19, almost 30% of the hospitalizations, and a disproportionate rate of deaths. And so that's really out of proportion to the numbers that we've seen here. So, and then also when you add in additional factors like chronic diseases and underlying chronic diseases that are more prevalent in some of these populations, you can also see that the risk for COVID-19 is compounded by some underlying chronic diseases in vulnerable populations.
So these populations have been vulnerable and have been for a while when it comes to health disparities. This virus has really pointed it in that direction more specifically.
Yeah, absolutely. So yeah, these are not things that we just found out because of COVID-19. I think they have just been more pronounced and more visible because of the way the pandemic occurred and how quickly it started to take our communities down. So yes, absolutely, this was here before, but really just a shining light on it because of the pandemic.
Dr. Cohn, at the onset of coronavirus, the American Cancer Society endorsed limiting annual cancer screenings for non-essential routine office visits. Now, since then, hospitals nationwide have seen a significant drop in cancer diagnosis. I'm assuming this drop is because of the fact that there was a drop in testing, right?
I think that has a lot to do with it. And, at the beginning of the crisis, I think that hospitals did a great job of letting their patients know that we should really minimize the amount of traffic through our healthcare systems. So decreasing the non-essential visits, the non-essential surgical procedures, and that includes some of the screening mammography or colonoscopies. And so at this point in time, when you shut off that, entry level to a hospital for cancer diagnoses, you're going to see less cancers that come through the door. I think the most important thing to recognize now is that towards the back end of this crisis, as we're beginning in the recovery phase now, it is safe to be back within our hospital system. And as screenings for colonoscopy, for colon cancer, for breast cancer, cervical cancer are now reemerging and now are open for our patient population, it's just critically important to let our patients know that they should be getting back on the schedule. And so whereas a 6 or 8 week delay in getting a screening test isn't going to do anything to delay a diagnosis of a cancer that's going to have a bad outcome, if you push that off for 6 or 8 months, that's when things can become more serious. And I think it's just critically important for patients to realize that, you know, hospitals and clinics are open. We're in a position to now accept patients back into the system because it's safe to do so.
And have you experienced that at the James, Dr. Cohn, that you have seen a leveling off or even fewer cases of these types of cancers the last few months?
I can't say that we've seen a meaningful change in the number of patients that, you know, we see through our doors. We're doing a lot of telehealth, and I'm sure we'll talk about that in a bit. But, you know, the cancer incidence hasn't changed because of this, you know, relatively small delay in screening tests. But again, it's just the biggest fear of having patients that delay it beyond this, in which case you certainly could begin seeing both a delay in the diagnosis, a decreased number of cancer patients, and a worse outcome, you know, when patients are ultimately diagnosed.
Dr. Thomas, talking about screenings and testings, are any of the COVID-19 tests that we're hearing about diagnostic testing to find out if someone has the disease or antibody testing, are these testings becoming more accurate and more available?
Well, in terms of the accuracy of testing, I think when you look at the test actually for the virus itself and then the antibody test, there's really two separate issues. The test for the virus itself, there are two main ways that those tests are done. They're either with a wet swab or a dry swab. There's a PCR test that's done in a lab. There are also some rapid testing that's done by Abbott through a more portable machine that can be done kind of closer to where the patient is. It's important to make sure that wherever you go, that the hospital you go to or the healthcare provider you go to knows what they're doing. So we have, between our lab staff and our infectious disease staff, various criteria for which type of tests go to which testing machine. So for example, the Abbott box, which is the rapid test, you can get an answer back sometimes in 15 to 30 minutes. It is not for asymptomatic people that are being screened to have David do their surgery. It's just not accurate enough. It's only accurate and felt to be accurate in people that are symptomatic because they most likely have higher amounts of the virus in their system. So it is important to make sure that when you're getting tested, you're going to a place where they know what they're doing. We do have some concerns. There is some swabbing going on in the state with anterior nasal swabs that are self-administered as opposed to a nasopharyngeal swab, which is administered by staff. There are still some concerns about the accuracy of getting enough of a sample with the anterior nasal swab. I think more research needs to be done and to make sure that it's accurate enough. On the antibody side, it's actually far more complex. On the antibody side, there are multiple different types of tests on the market. There are essentially home tests that you can do that are actually much more like a pregnancy test, to be honest. It is just a binary plus minus. There are significant concerns about the accuracy of those tests that are out on the market. The FDA cleared a number of things to be put on the market relatively quickly to try and be responsive to the pandemic. And some, in the New York Times has done a great expose on this. Some of these have 20% false positive and false negative rates, which you might as well walk in the other room and flip a coin, really. I'm not sure what the result tells you. Now, there are a couple that are better. The state is using one from Celex to do prevalence testing across the state. It seems to have a little bit better, a better response or better accuracy. And then there are different types of lab tests that are done at the hospital lab. Most of them out there, all they do is tell you if you have the presence of the antibody or not. The thing that has been a misperception in the community and businesses and even in the medical community, just because you have the antibody doesn't mean you're now immune. We don't know that it means you're now immune from getting infected again. There are anecdotal stories from Asia of people getting infected a second time. There are anecdotal stories coming out in the US of people getting infected a second time. Just because you have the antibody doesn't mean you're immune. Now, there is a different type of test that's it's a neutralization assay where it says not only do you have enough antibodies to be immune, but the right antibodies to be immune. So not just sign that the disease was there, but the fact that you have antibodies that can kill it. In those cases, if that test is positive, we do think those people probably have immunity based on the history of coronaviruses, maybe anywhere from 9 to 18 months, probably not forever. Most coronaviruses that cause the common cold, as most people know, you get it again next year. Sometimes you might even get a different one from a different kid for coming home from daycare, right? In the same season. But we do think if you have those neutralizing antibodies, you're probably immune, but that's really, those tests are few and far between. Not many hospitals are doing them. We have one that's in the research phase now that hopefully will be ready in the next couple of weeks. We're mainly using that to determine which patients are good to be donors of plasma to help other patients. It's not something that can be wide scale done in hundreds of thousands of people. But the antibody test that can be done in the lab, at least it tells you if you've probably had it or not, but it's just not at this point a guarantee of immunity. Sorry, that's a long answer to a short question, but
it just goes to show how much we're still learning. Like you said, every day, every week, things change or you learn more things, and that's where we are in this process.
Yeah, one of my colleagues that we work a lot with the state, he likes to use the phrase, we just met this virus a couple months ago, and we're all still getting to know each other. And I think that exactly is the case.
Dr. Olayiwola, what are we doing at Ohio State to address the health disparities that you talked about earlier?
Yeah. Thank you for that question. I feel very fortunate because at Ohio State, we were already really well positioned to tackle some of the health disparities that we ultimately have seen with COVID-19. The medical center already had a health equity steering committee that's been doing tremendous work across the medical center and all of our catchment area. We have a Partners Achieving Community Transformation PACT program that's a nonprofit entity affiliated with our medical center that's been doing a lot of work in revitalizing the communities on the Near East Side. So I think with that, and then having a number of other people and senior leaders across the institution and staff and employees that were very interested in health equity, we were able to mobilize a lot of people very quickly to action as soon as we realized what was going on. One of the first things that we did was we collaborated with the Health Equity Steering Committee, the PACT folks, our College of Medicine leadership, and Office of Diversity and Inclusion, which has national leaders that are well-renowned all over the world for their work in implicit bias and improving disparities and achieving equity. And we convened a national thought conversation where we gathered people from all over the country to talk about these issues in populations that have been made vulnerable, and also talk about ideas that we could all share and collaborate and explore together on improving the situation. So we had over 1,300 people register for our conversation. And because of those conversations that we had, both internally and with people around the nation, we felt like we needed to mobilize pretty quickly. And as people started to prepare to go back to work, and we recognized some of the challenges that many people were having with getting access to things like masks or hand sanitizer to be able to go back to work effectively or be safe in their own environments. Last week, we had a tremendous outpouring of support for a week-long community care kit distribution campaign that this group of folks in collaboration launched. We were able to distribute 46,000 masks, I believe 36,000 soap containers, and over 20,000 hand sanitizers to 5 zip codes that we targeted and populations in those zip codes. So as you're seeing on the screen, we had great support. Congresswoman Joyce Beatty joined us, Mayor Andrew Ginther joined us, and the Columbus Public Health Commissioner, Dr. Myshika Roberts, also participated. It was a great showing of support and commitment to serving some of our most underserved communities in Central Ohio. And following that, we've been using that coach that you see in the picture as our community care coach, which we really launched as an effort to bring primary care and prenatal care to underserved communities throughout Central Ohio in March, literally just a couple of weeks before the coronavirus pandemic took the turn that it did. So instead of having it sit idle, we've actually redeployed the coach to be a unit that we could use to help with the mass distribution, but more importantly, and coming up very soon, as a site that we can serve as an additional testing foreground for the medical center. So I think that we've done a lot of work that was already prepared us to be ready for this. Having a coach that was ready, having such great commitment across the medical center from all levels of leadership and staff and students to be able to engage. And then now we're kind of positioning for what is the long-term impact? How do we leverage all the partnerships that we've built through the PACT program that's led by Autumn Glover to be able to actually sustain some of the improvements that we will need in the long term.
Those are great pictures. Thank you for sharing those with us. And I do want to remind folks now, if you would like to submit your questions, we will take a look at those in a little bit. And we're going to continue now. Dr. Cohn, the James third largest cancer center in the nation. We're fortunate to have it here. But with the reopening, how will you continue to serve all 50 states? And people will be traveling and all those things that make everything more difficult with COVID-19.
Yeah, and I think, again, that's, speaking to Dr. Thomas's comments, that controlling one's environment is really the key to minimize this community transmission of COVID-19. Being a referral center in the region, across the state, obviously, and across the country and the world, really just increases the complexity of the impact of COVID-19 on our population. That, combined with that susceptibility of the cancer population, really does kind of increase the stakes and the risk. So we've done a lot of things, as we talked about in the beginning, about how to protect that vulnerable population. But I just do want to mention that telehealth is something I think that's been in the news repeatedly about how what we're used to be doing face-to-face has now transitioned very quickly to being able to do this by telephone or by video chat, similar to what we're doing this evening. And so immediately with the onset of COVID-19 pandemic, the Wexner Medical Center and the James very quickly began performing a lot of our visits by telehealth, trying to figure out in which patients can we not sacrifice the quality of care that we're delivering, and do so in a way that a patient doesn't have to leave her or his home and be in this hospital or clinic environment. So I think this is a really important component by which we can continue to serve the city, the state, the country, and the world for patients that need our expertise. Beyond that, again, it still is very important to recognize that there are visits that are required to be here. Someone who requires a physical examination, someone who requires an injection, a lab draw, or an infusion. These are things that we can't do at this point in time remotely, but we're still looking through and trying to find, important technological advances that we can identify that's actually going to be able to leverage what we do in the cancer program to the advantage of our patients not having to leave their homes and potentially risk their environment being exposed to COVID-19.
Dr. Thomas, and maybe the rest of you, excuse me, have thoughts on this as well. What are we learning now that will help us deal with the next pandemic, a future pandemic? Dr. Thomas first.
Well, I think certainly no longer being in denial, I think will be a really big part of recognizing when the next pandemic is coming. Frankly, with SARS and MERS and H1N1 over the past decade, we've been lucky to not have this happen before. So whether it comes to being prepared with stockpiles of medications, I mean, it got down to the point where we were literally running out of the swabs that you put in people's noses to do the test. It's a pretty important piece of the equation. So we've been able to 3D print those, but whether it's ventilators or certain medications, I think we'll be better prepared. I also think that it's sad to think that people are not going to feel comfortable ever again going to a football game or a baseball game or a concert. I do think the pendulum will swing back where people will be more comfortable with that. At the same time, I think it's going to take a while for people to really, from a societal perspective, feel comfortable in those settings. And maybe that's okay because people will be a little more aware of their surroundings. But I do hope that with the vaccine, really that's the thing that's going to get us out of this. And if some new technology comes out about how you create vaccines, as most of you know, there's been stories that usually take sometimes up to 5, 10, 20 years to create a vaccine for a new virus. They hope to get it done in 12 months. There have to be some new innovative technology that will come out of that work so that for the next pandemic, we'll be much better able to respond. So I think we won't be in denial and we'll be better prepared.
Well, speaking of research then, I'm going to shift over to you, Dr. Cohn. The James is known for their research, for their clinical trials that move that cancer treatment forward. So how has the research at the James been impacted by the virus?
Yeah, it's been very severely impacted by the virus for the same reasons we've discussed, that traffic through the system has to decrease initially. And so we began recognizing that there were certain clinical trials or studies that were not providing specific benefit to the patient, in terms of his or her cancer treatment, but might provide benefit to science. And so in an effort just to control environment and to reduce the risk to that individual coming into our healthcare system, those were closed relatively quickly. They're back open at this point in time over the next couple of weeks. And so I think we're very fortunate to have only been a relatively short period of time without our, some of our clinical trials. That being said, the important trials that really advance the science and that improve patient outcome, those were able to continue throughout the pandemic of individuals that were on the important treatments that were improving their outcomes and quality of life. But the other thing I think that we learned through this process is that through the research that's been done at the James, there were a couple of innovations that actually were used in COVID-19 treatment. For example, certain chemotherapy drugs were shown to be effective against COVID-19. And so those drugs very quickly pivoted from being cancer treatments to COVID treatments and are currently being investigated. And likewise, data from other viruses and other pandemics that showed that radiation to the lungs might speed up the process of healing for COVID. That's another clinical trial of using a cancer treatment instead of for cancer, rather for COVID-19 therapy as an experimental treatment to see if we can expedite the recovery from COVID-19. So it's been quite a ride, I think, through COVID-19 as it relates to the clinical research that's been done. And obviously the laboratory research has been dramatically impacted as well. And that took a temporary shutdown and is in the process of reopening the important discoveries that are going on in our basic science laboratories.
Dr. Olayiwola, let me ask you about how the community can help with the efforts that you've shown that Ohio State has started, that I know others are working to as well, to help decrease some of these health disparities.
Yeah, thank you. I agree with my colleagues that we've learned so much during this pandemic that will hopefully prepare us to be rock stars in the next one. But one thing that I think is really important to sustaining some of the work and making sure that we are prepared for whatever might come in the future and whatever the return to some sort of normalcy will look like is, kind of immediately, we do need to get people things like masks. And so, as I mentioned, we had a really successful campaign last week to get masks out to people over our underserved areas, but we were looking at doing a phase 2 of that, recognizing that we did not have enough, nearly enough for the people that needed them. Now we're thinking, should we do this as cloth masks as opposed to the non-isolation masks and making it easier for people to reuse them? So really, thinking about how do we support ongoing efforts to provide that level of protection for people that are going to be entering the workplace or going out in the communities. Also, just how do you make sure that some of the structural and systemic challenges that many of these communities have had can be addressed proactively going forward? So we've got a healthy community center that we're in the early phases of building out, formerly the MLK Library on Long Street in Columbus, and we're converting that space into something that allows for education, community-based programming, healthy lifestyle teaching, teaching kitchen, a retail cafe, food market, things like fresh food market, things like that, and being able to provide those kind of resources so that you can address some of the social influences on people's health and the economic influences on people's health in a more proactive way will be other things that will be really important for us as we go forward. So I'd say in the short term, just making sure we get the supplies, the masks, the care kits, whatever support is needed for testing supplies and awareness building, but then also long-term sustaining programs that have these deep community partnerships, training and education, as well as these place-based solutions to community challenges.
You spoke about this opening up on the East Side. Where are you with this project? Is it something that is going to open in a year? Did it have to be sidelined because of COVID-19? Is it still, are you partnering with the city?
Yeah, so definitely.
That's three questions. Sorry.
No, it's a great question. I think we're still in the early phases, and as many things have been said earlier tonight, that we have had to sideline some of the effort because of the COVID-19 situation, but excited to get back into it. I think we've got a lot of goodwill that's been built up in our communities. We have a lot of support from a number of different partners to move forward. And so we're really working, it's still in the early phases. We've kind of mapped out what it will look like, what are all the resources that we need to have in there, what are the things that the community members want to have that they feel like they don't have access to. So I think that's a very, really important opportunity for us to develop and work with our partners that have been so supportive of all the work that we've done at the medical center.
Dr. Thomas, do we really anticipate a second surge?
Fortunately, we do. I think the fear is that that second surge of coronavirus will come right about the same time that the typical annual surge of influenza comes. So that's, I think, probably our biggest fear. Certainly, as we've seen before with H1N1, a little bit with SARS and MERS, over the summer, this will most likely go down a little bit, but then in the fall, as people are huddled more in indoor spaces, more closely confined, but when you think about what we've been able to do since, say, early March or the middle March to now, we've bent the curve as a community, as a society, as a state. I think there's going to be even more we're going to be able to do in the fall than we typically do for influenza. We've learned a lot this spring. I think that in my mind, the important part is, will people sustain these efforts through October, November, December? I hope they will. I think they will. I think, we're all hopeful there'll be a vaccine. It would be great if it was here by the end of the calendar year. I think that we have to be prepared that it won't be. I always like to hope for the best, but prepare for the worst. In my mind, we are going to have some sort of a surge, but the question will be, will we be able to bend the curve again like we did this time? We didn't see that big spike. We saw more of a plateau, and now it's going back down a little bit in terms of hospitalizations, at least. So I think the other thing is we talk about herd immunity, where you need to get 70 to 80% of a population infected or vaccinated, and then it stops it from going through a population. I actually like to think about herd masking, right? And herd social distancing. If 80% of the people do the masking right and the social distancing right and washing their hands right, that's what prevents one person from giving it to 2.5 people. That's one person gives it to maybe not even one person, less than one person, to keep it. It'll be back, but it won't be like this. It'll be more of something that at least the healthcare system can handle, and we won't need to stop elective surgeries. We won't need to stop colonoscopies and heart caths and other things like that, like we've had to this spring. That's my goal.
Thanks, Dr. Thomas. A question now for you, Dr. Cohn, from someone who's been viewing. How has philanthropy helped the James during this critical time in healthcare?
So philanthropy is always helpful in our operations and certainly in our research efforts as well. And so it's been able to sustain some of the ongoing critical research that we've been doing. And I would just call out that there's been a specific philanthropic effort that addresses COVID-19 in the cancer population as well. We know, as I said, that it's cancer patients are susceptible to infection and they're susceptible to complications if they were to get COVID-19. So beginning to really understand what we can do to protect this vulnerable population through the second surge that Dr. Thomas talked about with whatever it's going to be, COVID 20 and 21, we've got to think about other opportunities that we can identify the risks for cancer patients getting COVID and also their outcomes. So as we began shutting down screenings and testings, we want to really study the population as to your question, Gail, what happens? Are we going to see less cancers for the next year or 2 years? And how can we really address that for future pandemics to make sure that we're not jeopardizing the population health when it comes to cancer risk as well?
Okay, thank you.
Can I address philanthropy more?
Yes.
Oh no, can I address philanthropy more broadly as well?
Yes.
I know a number of folks on the call or on the webinar tonight are big supporters of the medical center, and I know many of them have been personally supportive of a number of us professionally and personally over the years. But I can tell you the community's outreach and outpouring feeling for those folks that are at the bedside, doctors, nurses, respiratory therapists, whatever it is, even people that aren't taking care of COVID patients but are still going into work every day and taking care of patients. I just can't thank the folks on this call and the entire community enough for the outpouring of emotion. We've had flyovers by the National Guard. The police have driven through and recognized. It's been great to see. Even Easton, the restaurants at Easton, I heard today 8,000 meals have been donated to the medical center by the restaurants at Easton. They tend to come in the evening time around dinner. It's been just wonderful. We've had a number of work groups around the coronavirus. One is about the health of the workforce and an employee well-being. We've had donations to support hotels for staff to stay in if they don't feel comfortable going home, all sorts of things that just have been innovative ideas from the community that Patty Hill Callahan and the team have been managing. Donations of supplies, donation of masks, all sorts of things. I just can't thank many of the folks on the phone or on the webinar tonight enough. It's been a terrific feeling. Thank you.
And Dr. Olayiwola, I do have a question, and I'm going to try to summarize it because it's a long one, but I think basically what this viewer wants to know is, with these new telehealth capabilities and trying to keep people out of the hospital or clinics as much as possible, how is that further putting a barrier for some of these folks who may not have internet access and other things that make it more difficult for them, maybe even to do telehealth?
Yeah, no, that's a fantastic question. Thank you for asking that. One thing that is really important to think about here is that as we change the way we deliver healthcare and we start to convert to more digital care, I want to make it clear that people recognize that we're doing everything we can at the medical center to make sure that people still have choice. And as Dr. Cohn said earlier, there are just some clinical scenarios that do not lend themselves to being done by telehealth, but for those that do, we want people to have choice. And as we're phasing our reopening very, very thoughtfully, we're thinking about those kind of things. We want to make sure that we're still taking care of people's chronic diseases and making sure that in-person visits happen if that's what people strongly prefer. But however, the risk that we have of kind of the rapid expansion to telehealth and ongoing, continuing telehealth, particularly in the communities that I talked about that have been made vulnerable for multiple reasons, is that you do kind of widen that digital divide that already exists. And so as you're thinking about expanding telehealth services to patients across the region, across the nation, frankly, we've had, and I've had it in my own practice, patients that absolutely cannot connect through the video visits because of some sort of broadband limitation. They would say, well, it's just easier for me to call you. Maybe they don't have necessarily the technological capabilities or literacy that might be needed for some of these types of visits. So as we're thinking about the paradigm shift in the way that we deliver care, we absolutely have to be planning for what kind of structural supports do we need to make sure exist in these communities. And that's the kind of thing I was talking about through our PACT program, is really looking at not just individual patients, but a holistic way. How do you improve all the structures that need to that will support a community in being able to be successful? And so things like broadband capability, what kind of access do people have in their homes? What kind of tools may we be able to provide to people? If we say, here, here's this tablet, go home and then I'll connect with you on a telehealth visit, and I've equipped you to do that. Those are the kind of things that we should be thinking about as we're thinking about these shifts.
Sort of what they did with the school system to help parents who are teaching. It would be something that could be done possibly in the medical community, I suppose.
Absolutely, absolutely. One
last question, and this is going to be for all of you, and then we will wrap for this evening. What keeps you up at night regarding COVID-19 and what you shared with us? And I'm going to start with you, Dr. Thomas, because you talk about somebody who's been on the front line. You have been working on the governor's task force, and you see a lot of things in every sector.
So I think our biggest, the biggest things that keep me up at night are congregate settings, places where groups of people live, especially people that are brittle, elderly, have underlying health issues, underlying cognitive dysfunction. We work, one of the big parts of the Zone 2 work that we do is working with nursing facilities, assisted living facilities, memory units, jails, prisons, state psychiatric hospitals. Obviously, those are places where visitation's been limited. The vessel that brings it in is a staff member. It's incredibly complex because you can go out and test tens of thousands of people, but 3 days later, someone could bring it in because they've gone to Kroger or went to church or went to their cousin's house. And so that's probably the thing that worries me the most. I do think in general, people in the community are taking this seriously. But it's probably the thing that worries me the most, because those are people, to a lot of Nwando's points earlier, those are people that are set up to get sicker, to have worse outcomes. They're older, they have more underlying health issues. And that's probably the thing that scares me the most.
Dr. Cohn.
And so certainly I echo Dr. Thomas's comments. I would add to that, though, from the perspective where I am in the cancer hospital, the thing that worries me the most is that's another vulnerable population with that underlying health condition. And so just emphasizing the importance of all the things that the CDC is recommending in terms of hand washing, physical distancing, wearing a mask, controlling the environment. And then, as I mentioned before, it's the fear that individuals are not going to be comfortable reaccessing healthcare again and delaying these really important interventions that can keep them healthy for the long term because they're concerned about their health in the short term. And it's just the emphasis that, across the country, we've learned so much about COVID-19 and how to keep communities safe, that it is safe now to be back in the healthcare system and to do the things that are necessary for health maintenance in general health and cancer screenings as well.
Okay, Dr. Olayiwola.
Yeah, thank you. I guess none of us are really sleeping, I guess, because we're worried about the same things. But I agree with both of my colleagues. The only other thing I'll add is that the thing that really worries me is what are the kind of long-term mental health impact on people that have been so fearful, that have lost their jobs, that have seen their lives really turned upside down by the effects of the pandemic, and how are we going to be prepared to be able to accommodate that? So the cumulative stresses that build up, particularly in the communities that we've been talking about that have been most vulnerable, will lead to certainly a number of different mental health realities down the line, and more depression and anxiety and substance abuse. And so how will we be prepared to be able to take care of those needs once we kind of get to the other side of everything here is something that I've been thinking a lot about, and hopefully that we'll be equipped to do that. And provide our people with the kind of resources and support they'll need to be ready and to be kind of thrive again.
One of the most difficult parts of all of this is that we are innately social beings, and telling people not to do that. As Dr. Thomas said, hope they can do that for the next few months, next year, but it will be hard. It will be hard. Thank you all for joining me this evening. Unfortunately, we're out of time. Dr. Cohn, Dr. Olayiwola, Dr. Thomas, thank you for being with us this evening. And thank you all for joining us. And I hope you'll join us next time for up-to-the-minute information about COVID-19 from the front lines. And if you're interested to help, please visit the website on your screen and join Ohio State in the fight against coronavirus. Thank you. Be safe, be well. Have a good evening.
Thank you.
Thank you.